Welcome, ladies and gentlemen. My name's Priscilla Wadham and I'm Manager of the Alumni Relations Office at the ANU. I'd like to welcome you to the second of our ANU alumni-sponsored research series public lectures this year. The idea of the lectures is to showcase current and major research achievements from the ANU. We're delighted to have you with us. We actually hope to roll out about 6 or so similar types of lectures next year, so watch this space and we'll keep you up to date on what our plans are. Before introducing our speaker this evening, I'd just like to acknowledge that I'm honoured to be on the ancestral lands of the Ngunnawal people. I acknowledge the first Australians as the traditional custodians of this continent, whose cultures are among the oldest living cultures in human history. I pay respect to the elders of the community and extend my recognition to their descendants who are present this evening. This evening's lecture is psychological distress in people living with cancer related to the diagnosis, current treatment or level of disability, will be delivered to us by Professor Emily Banks. Professor Banks is a National Health and Medical Research Centre Senior Research Fellow at the National Centre for Epidemiology and Population Health in the ANU College of Medicine, Biology and Environment. And she's also Scientific Director of the New South Wales 45 and Up study at the Sachs Institute. Emily has internationally recognised and respected expertise in pharmacoepidemiology and extensive experience in quantitative evaluation of the risks and benefits of medicine. Please come in. She is a member of the Million Women Study Steering Committee and a former advisor to the World Health Organisation Human Reproductive Unit. Professor Banks was the winner of the UK National Woman of Achievement in Science and Technology Award in the year 2000. And she's former Deputy Director of the Cancer Research UK Epidemiology Unit at the University of Oxford. On Tuesday evening this week, she received an ANU Staff Excellence Award in Career Achievement from the ANU Vice-Chancellor, Professor Chubb, for her outstanding academic achievements since commencing at the ANU only 6 years ago. We'd like to welcome Emily to the podium. Thank you very much.
Thank you very much, Priscilla. And I'd like to thank the organisers for giving me this opportunity to speak to you this evening. I'd like to start by saying that I'm an epidemiologist, which means that I work on population health. My background is in medicine, but also in looking at large-scale studies to evaluate the effects of common exposures on common conditions. So I really focus on looking at populations rather than on individuals. So today, today I'm going to be talking to you very specifically about the question of whether psychological distress in people living with cancer is related to the point of diagnosis, to their current treatment, or to their level of disability. And before I start on my talk, I'd like to acknowledge, I often put the acknowledgements at the end, but I actually think it's better to put them at the beginning. So this is a new departure for me, to put the acknowledgements up front, which is to say, first of all, I thank the people who participated in this study and who gave freely of their information and quite intimate details about themselves to let us look at this. I also thank Beyond Blue, the National Depression Initiative, for funding the research, and the Cancer Council of New South Wales and other 45 and Up study partners and supporters. I also thank the team of people who helped to recruit the people into this study, and my investigators who are listed, my fellow investigators who are listed there. Now, this talk is specifically about the question, is psychological distress in people living with cancer related to their diagnosis, current treatment or level of disability? And I recognise that many people in the audience may have had cancer or know people with cancer or have been touched by cancer in some way. So I also wanted to say that this talk is not about the risk factors for depression in cancer survivors. So it's not a sort of general look at what predicts depression in people who have had a diagnosis of cancer. It's not about how to avoid depression in people with cancer, and it's not about the mechanisms that cause depression in people with cancer. And it also doesn't include a detailed description of people's feelings. In fact, in some ways, it's using a rather blunt instrument. So I'm not saying this I'm trying not to sound apologetic about it, because I think that what I'm going to talk about does provide insights into the relationship between cancer and psychological distress. But I also don't want to have a false advertising here that I'm really going to be talking about what it feels like to have cancer, or all the different emotions that happen during that time, and all the things that are raised there, because it's really beyond the scope of this kind of large-scale study to really go into that kind of depth. But that's not to say that it isn't important, and I think that what I'm going to be presenting today, it really needs to sit alongside the other research about people's feelings following a diagnosis of cancer and going through the treatment process. So it's really a very large-scale look at factors relating to high psychological distress in people with cancer, but it's particularly looking at answering that question of, is there actually something inherent in the diagnosis of cancer that causes depression long term, or is it related to disability? So I'm going to do a very typical scientific presentation here. I'm going to give you some background about epidemiology and about the area. I'm going to talk about my aims, methods, results, and then some conclusions. And I'll be leaving, hopefully, plenty of time for questions at the end. So I think a lot of people think of epidemiology as producing this kind of thing. So this is today's random medical news, and you can see you just spin the wheel and it says exercise causes breast cancer in 2-income families, or any one of those sort of random pieces of information. So I think we turn on the television and we suddenly get some whole new thing. And often it's portrayed in the media as, it's not sexy in the media to say boffins agree yet again that smoking causes lung cancer. It's much more interesting to have points of disagreement or sensationalisation. So there are some people who view epidemiology in this way, but I think Leunig is better. This is obviously some US cartoonist. But this is what I think epidemiology is. So we have this kind of seething mass of humanity out there. We're all going about living our lives. It's a complete mess, really. And epidemiology gives us an understandoscope, because there are certain people out there who've joined studies, who've filled in questionnaires, who've allowed us to ask them detailed questions about themselves. And it's these people who provide us with that window on the world and let us understand some of the underlying relationships. So it's those people who are providing the kind of data. So I'd like you to keep that idea of the understandoscope in your mind while we go through this, but also note that that there really is a whole world out there, and it's only it's not such a large proportion of the population that let us look at them. We've been very. I'll go on to talk about the 45 and up study and the fact that it actually is. It gives us a lot of insights into disease causation. So, as background, we know that there is an elevated risk of depression and high psychological distress in cancer survivors, and that isn't particularly surprising. It's a very distressing diagnosis. There's a lot of concerns about people's survival, and there are also difficulties that go with treatment and with the sequelae of having a diagnosis of cancer. We also know that in the general population, physical disability is one of the strongest risk factors for having psychological distress. So if you look just out there in the general population, if you're not able to do what you used to be able to do, then in general, you're at an increased risk of psychological distress. So, but that second relationship is complex, because if people are depressed, they're more likely to perceive any sort of symptoms or disability as problematic. So, and actually, severe depression can actually lead to disability. So there's a sort of cyclical relation, there's a circular relationship there. We also know that people are increasingly surviving for long periods of time, or living, in fact, normal lives following a diagnosis of cancer. So we actually need to pay attention to that quite large group of people who've had a diagnosis of cancer in the past. And one of the things that we've sought to address in this research is what the risk of high psychological distress is like in people who are long-term survivors. The evidence that we have so far, so prior to the publication of these results, was that we knew that there was increased psychological distress in people who had a recent diagnosis of cancer, and also in people who have advanced disease. We also know that studies of very specific groups of patients, like people who have lung cancer and people who have ovarian cancer, that physical functional impairment, that is disability, was the most important predictor of high psychological distress. But we don't really know if that elevated distress persists long term. And we don't really know if people who are long-term cancer survivors in the absence of disability are still at an increased risk of psychological distress. So what we really have had before these data were published was a lack of data on disability and psychological distress for the wider population, including long-term survivors, and for multiple cancer types. So what we had was sort of specific, almost case series where doctors would recruit or follow up people in particular patient groups and look at their risk of psychological distress. So the aim of this study was to investigate the separate and combined relationships of cancer diagnosis, treatment and functional impairment, and I'll go on to define that, with psychological distress. And you'll see down the bottom I've listed the publication here. So that there are copies of this publication on the table outside that you might have already picked up, but feel free to pick up one on the way out. So the methods of this study were that we took data from around 90,000 participants in the 45 and up study. And these people were recruited from February 2006 to April 2008. And this is a subset of the broader 45 and up study, which went on subsequently to recruit 266,000 people. So when it was completed, it was about 10%. It's about 10% of the New South Wales population, 45 and over. So it's a very, very large data set. We focused on this group because at the point when the analyses were done, that was the group where we actually had the data. People were sampled through Medicare Australia. So Medicare Australia posted out a questionnaire to people and invited them to take part in the study if they wanted to, on the understanding that Medicare had not passed out any details to the researchers of those prior to mailing it out. And then people filled in, if they wanted to join the study, they filled in a questionnaire. This is blue for the men and pink for the women. And then they posted it back to the study with their consent for long-term follow-up. Now, about 18% of people from the general population who was sent the questionnaire completed it. So it's not designed to be a representative study. It's not like a sort of Australian Bureau of Statistics survey of the proportion of people who smoke or drink. It's actually called a cohort study. So it's designed to allow valid comparisons within the study, but it's not designed to provide a kind of snapshot of the general population. And in fact, we oversampled in rural areas and also among people 80 plus because we didn't want a representative sample. We wanted enough spread of exposures in the population to be able to look in all the different population groups. Now, I know someone is going to ask me about representativeness, so I've included some slides at the end for when people ask that question. But, you know, you can save it up. Okay, so all of the variables for this study were derived from the questionnaire, except for region of residence, which was from the postcode given to us, the postcode of residence according to Medicare. So it's based on what people wrote on their questionnaire. The main variables that we're looking at here are whether the cancer diagnosis and some specific types of cancer, whether or not they'd been treated, measures of disability, psychological distress, and then a range of other factors which we also wanted to adjust for or account for and make sure that we're actually getting the independent relationship of the diagnosis disability in relation to the psychological distress. And just for the people who are interested in stats out there, we used an unconditional logistic regression model, and we used psychological distress as the outcome, which is adjusted for age, sex, and income and education in most of the models. So in terms of I'll just take you through how each of the variables. So whether or not someone had cancer was coded according to their answer to the question, has a doctor ever told you that you have? And I'll just do, there's a little square around it. So they answered first whether or not they'd had skin cancer, which was not melanoma. But in fact, when we're talking about cancer in all of these analyses, we actually included those people as not having cancer if skin cancer was the only diagnosis. So, but we do look at it specifically as a type later on. So when I say cancer in relation to psychological distress, I'm excluding skin cancer because it's not seen as sort of serious enough. We do include melanoma. For men, we asked specifically about prostate cancer. And then we had this box called other cancer, where people could write in what cancer type they had. Now, at the time when we did these analyses, there were tens of thousands of people had written a different cancer type in there, and it hadn't actually been coded it hadn't been entered in the data. So in terms of the cancer types that we can look at, we know if someone's crossed, yes, I had other cancer, but we weren't coding these. So when I go on to talk about specific cancer types, we're going to be able to look at melanoma, prostate cancer, breast cancer in women, and skin cancer. But we won't be able to look at any of the subsequent cancers. And in fact, what we're planning to do is that we will look at those in relation to cancers that are registered through the New South Wales Central Cancer Registry, rather than based on people's self-reports. We also looked at, so that's the ever having a diagnosis of cancer. We also asked, in the last month, have you been treated for a whole range of conditions? But what we're focusing on here is whether or not they said yes to being treated for cancer. And then we also looked at disability. Now, we had two main questions about disability. The first was, do you regularly need help with daily tasks because of a long-term illness or disability? And we've got in there examples of personal care, getting around or preparing meals. And this is a well-established question about disability. But it's quite a serious disability if you require help with daily tasks. We also have a scale that gives us a sort of broader spread, which is, does your health now limit you in any of the following activities? And these are really physical. This is called the medical outcome score, physical functioning, and these are really physical attributes. So we're talking about whether or not you're limited in vigorous activities, moderate activities, lifting or carrying, shopping, and then climbing stairs. And then there's also walking 1 kilometre, walking half kilometre, 100 metres, and then we get right down to bathing or dressing yourself. So this is used to create a score that goes from 0 to 100, and 100 being no limitation, so that's people who've just ticked all down that side. And then there are people, then we've also coded into minor, moderate and severe limitation. So you can see that the first score is quite, it's readily, you can really readily understand what people mean when they say that they need to help with daily tasks. It doesn't give you a very good spread, whereas the second one gives us a bit more detail. And then in terms of measuring psychological distress, we used a tool called the Kessler 10. And this is these 10 questions. So it says, during the past 4 weeks, about how often did you, and then did you feel, and then it has tired out for no good reason, nervous, so nervous that nothing could calm you down, hopeless, restless or fidgety, and various other things such as depressed and worthless. This gives a general score about psychological distress. It actually contains both scores related to both depression and anxiety, but both depression and anxiety are actually very closely related. So I don't know how many psychologists there are in the audience, but you know that it's very difficult to tease out both of those two things. So it's actually quite helpful in the general population to really put it together in a score that's called psychological distress. Having said that, quite a bit of that psychological distress will be depression, because you can see that we've got these scores relating to feeling depressed, feeling tired out, feeling that everything was an effort, nothing could cheer you up, and feeling worthless. And those things are related to being depressed. And then there are obviously other elements of that score that relate to anxiety. So we defined a score of greater than or equal to 22 based on adding up all of these as high psychological distress. And I probably didn't point out here, but people indicate whether they felt those things none of the time all the way up to all of the time. So we also get a spread of how frequently that's affecting people's lives. Because quite often, I don't know about you, but whenever I look at these psychological scores, I always go, yeah, I've got a bit of that, and I've got a bit of that, and I've definitely got a bit of that. And I remember learning about personality disorders at medical school, and I was sure I had every single one of them, but apparently that shows you don't have one. Because people who don't have a personality disorder have a little bit of everything, and it's when you go too far into one thing that's problematic. Anyway, this actually is quite a good score from the point of view of letting you understand. You know, some people have a little bit of things, but it's when you get up towards the more extreme ends of the scale that we can say someone's got high psychological distress, and that correlates quite well with a clinical diagnosis of either depression or some sort of anxiety disorder. So I'm now going to describe the study population. Now this is the first 100,000 participants in the 45 and up study actually geocoded onto New South Wales. So they're each represented as a dot, a little bit fuzzy, so you can't recognise like a farm out of parks or because we preserve confidentiality of people. But what you can see is that we have a really huge spread across New South Wales. They're concentrated where the people are concentrated, which is up the eastern seaboard. You also note there is an unsightly hole, which is the ACT. We did try to get funding to recruit people in the ACT into 45 and up, but we were not successful. So it's a bit unfortunate. If anyone wants to make a push for having people in ACT and 45 and up, we'd be delighted. But anyway, at the moment, it's an unsightly hole. So looking then at the study population, I don't know if you can read these, but I've just done, this is the proportion of people with these characteristics. This is male and female, so we actually have quite similar numbers of men and women. I mean, this was just sending out a questionnaire to the general population, and there was a sort of assumption that men would be less likely to participate than women, but in fact we got 48% men and 52% women, which was pretty similar to what you would expect. This is age group from 45 to 49 up to 90 plus, and what you can see is the majority of people are in their 50s and 60s. We actually have about a third of the population in the study are 70 plus. So we've actually got quite a good spread of ages as well. When we look at education level, we have about 30% of people have either just a school certificate or less in terms of educational qualifications, and about a quarter are tertiary educated. We also have quite a big spread of incomes, and this income is in fact total household pre-tax income. So we have quite a lot of people who have actually very low incomes, and a lot of the people are pensioners because they're elderly. But we also have, so we have about a quarter of people have a total household income of $70,000 or more, but a bit under 20% have less than $20,000 a year to live on, which is pretty staggering. And then if we look at the spread of where they live, we're about half and half rural and urban. So if you look at the biggest group, that's people who live in a major city, quite a lot from inner regional, outer regional, and then a smaller proportion from remote and very remote areas, as you would expect, because there aren't very many people living out there. I also wanted to talk about the proportion of people who need help with daily tasks and in terms of their disability. So what we find is about 4.5% of people need help with daily tasks. And what's also quite interesting is we did ask people in this study if they were caring for somebody long term because of illness or some other sort of disability, and around 5% of people said they were caring full time for somebody. So within the study we've got the 5%, 4.5% who need help with daily tasks, and the 5% of people who are looking after people who need help with daily tasks. So there's a sort of natural balance there, I think. But what you can see too is when we actually classify things according to functional impairment. So we see 95% of people don't need help with daily tasks. But what we also see is that actually only about 30% of people actually have absolutely no functional impairment. And the rest of people are spread across this gradient, across this group. And we have about 15% of people who have a severe functional impairment. But what it's saying is a lot of people are managing on their own or without help with daily tasks, even in those categories. So just looking at the results now in terms of cancer, we actually had 16% of people in the study reported that they had had a cancer in the past, apart from non-melanoma skin cancer. So that actually told us that, and that's higher than we would expect in the general population. So what it actually told us is we've actually got an enriched sample from the point of view of cancer survivors. The people who've had cancer are actually particularly interested in joining this kind of study. The average time since diagnosis was 7.3 years. So we actually had a spread of people who from being recently diagnosed all the way to having been diagnosed quite a long time ago, but the median, that is 50% point, was 7.3 years. We also found in the study that 7.5% of people in the cohort were classified as having high psychological distress. So it's actually quite common in the community to have high psychological distress. And when we looked at the background factors that related to it, it was actually younger age. So if we're talking about people 45 to 105, which is essentially what we have here, the people who were 45 to 49 had the highest chance of having high psychological distress. In fact, you just get happier and happier and happier and happier until you hit sort of 70 or 80, and then it kicks up a little bit in the much older age groups. Now, because this is a snapshot or cross-sectional data, we can't tell whether that's the effect of being 70 or the effect of being born in 1940 or 1935, but it suggests, the gradient suggests that actually people get happier and happier. So it's I don't think many people appreciate that, but I think it's heartening for me, really. Looking forward to getting there. We also found increased psychological distress among people who had lower education, low income, and who were unemployed. People who lived in urban areas were less happy than people who lived in rural areas. People who spoke a language other than English at home were more likely, but not massively more likely, to have high psychological distress. And people who were current smokers who were either non-drinkers or heavy drinkers. So the people who were happiest were the people who had moderate amounts of alcohol. I don't know if they were drinking at the time when they filled in the questionnaire. Okay. So if we put together those results about cancer and psychological distress, and we have an adjusted odds ratio. Now I'll just explain what an odds ratio here is, because I think that is the main way I'll be expressing the results. So an odds ratio tells you how much you have to multiply the effect in the baseline group, what the factor you have to multiply by in the other group. So for example, if you have a relative risk of 2, it means that that thing is twice as common in the group you're looking at compared to the reference group. So if I say this group has an odds ratio of 1.5 for psychological distress, I mean that it's 50% more likely in the group I'm looking at compared to the reference group. So I'll keep talking about that, because I don't know if it's quite a difficult concept. So what we're looking at here is the adjusted odds ratio for psychological distress, high psychological distress that is, in people with cancer compared to people who've never had cancer. So what we find is that people who've had cancer have a 17% increase in the risk of high psychological distress compared to people who have never had cancer. And this is the 95% confidence interval, which says that the true value is likely to lie within this interval 95% of the time. So essentially what it means is that there is a significantly increased risk in people of psychological distress in people who have had cancer in this study overall. So that does mean that there's a long-term increased risk, but it's actually not particularly large. It's a 17% increase in risk, so it's not a huge increase. But what we do find is that there's a 30% increased risk. When we divide it further, there's a 30% increased risk, 34% increased risk in people who've had cancer diagnosed in the previous year, and a 50% increase in risk in people who've actually been treated for their cancer in the previous month. So it does suggest that there is an increased risk of psychological distress with recent diagnosis of cancer and in people who are actually undergoing treatment for cancer. Now, I'd like people to bear in mind that treatment for cancer could, if you consider that it might be treatment for breast cancer with tamoxifen, or it might be chemotherapy for something for a more recently diagnosed cancer, there's obviously quite a lot of heterogeneity in what is included in that cancer treatment heading. So what we're seeing there is an average. We also find in terms of disability that, as I've said, 4.5% of people need help with daily tasks, and cancer survivors are more likely than others to need help with daily tasks. So if they have had cancer treatment in the last month, they've got a 2.86 times increased risk of needing help with daily tasks compared to someone who doesn't have cancer. So what it's saying is cancer diagnosis is related to disability. But if they haven't had cancer treated in the last month, then they've got a 27% increased risk in their likelihood of actually of needing help with day-to-day tasks. So what it says also is that a lot of that disability is related to the treatment somebody's receiving, and that in the longer term there is an increased risk, but it's not as large as that. So finally, putting the disability and the psychological distress together, and then also talking about cancer, if you look at people who need help with daily tasks, about 30% of them have a K10 score consistent with high psychological distress. And what's interesting is that if you look at people who have both disability and cancer, it's about 26%. But if you look at people who have disability without cancer, it's very similar. So what it's saying is actually, in general, people who have some sort of physical disability that means they need help with day-to-day tasks, they actually have quite a substantial risk of high psychological distress. Among people who don't need help with daily tasks, about 6.2% of people have high psychological distress. So it's obviously not unheard of in that group. it's much lower. So this is really, if I was asked to do one picture, which was really summarising the results of this study, this is it. So I'm going to walk you through it fairly carefully because it really sums it up. Now this kind of plot is called a forest plot. Now I've looked into why it's called a forest plot, because I thought it was because they're so hard to get right. You need a forest of trees to, with all the printouts trying to get it right. But it's actually because it's meant to look like branches and a forest, but I can't really see it myself. Anyway, it's a forest plot. This line here is the line of no effect. So that's corresponding to a relative risk of 1. And so blobs on this line mean that there's no significant elevation in risk. The horizontal black or white lines are the 95% confidence intervals, which is where the true value is likely to lie. So points to this side of the line mean there's an elevated risk of psychological distress, and points to this side of the line mean there's a decreased risk. So the first thing to note is, looking at all these factors related to cancer and disability, there's nothing on the protective side. So all of the different factors we're looking at relate to an increased risk. So the reference group in this case is people who have never been diagnosed with cancer up here. That's a relative risk of 1. And we're now going to go through and compare people who've never been diagnosed with cancer with those who are ever diagnosed with cancer in relation to their relative risk of high psychological distress. So here we've already talked about this first result here, which is a 17% increase in the risk of high psychological distress among people ever diagnosed with cancer. And that's our kind of summary for the whole population. It includes people diagnosed recently, diagnosed a long time ago. It includes people treated and not treated. It includes people with disability and without disability. And here's our other, when we divide those ever diagnosed with cancer into people treated in the last month and not treated in the last month, we get that 50% increase in risk there with the treatment in the last month. And among people who have ever been diagnosed with cancer but have not been treated in the past month, we have around an 11% increase in risk. And when you're getting down to a relative risk of 1.11 or an 11% increase in risk, then you're really starting to get relative risks that are really hard to distinguish from the null. They could be accounted for by other things. So even though that's a significantly raised risk, it's sort of borderline as to whether it's necessarily meaningful. If we then go down to look at the effect of cancer and disability, which is what's happening here, we've got people never diagnosed with cancer here in this group and people ever diagnosed with cancer in this group. And the reference group here is people who have never been diagnosed with cancer and do not need help with daily tasks. So they're people who are able-bodied and haven't been diagnosed with cancer. And then if we look at the relative risk of high psychological distress in people never diagnosed with cancer but needing help with daily tasks, we come up with a 6-fold increase in risk. So if you've not got cancer but you need help with daily tasks, you've got a 6.5-fold increase in your risk of having high psychological distress. If we then go down to this group here, which is ever diagnosed with cancer, and we're still comparing them to people never diagnosed with cancer with no disability, so people who've ever been diagnosed with cancer but don't need help with daily tasks, we get a 14% increase in risk of psychological distress. So you could argue that there's a 14% increase risk of psychological distress in the absence of disability. So that could be that amount that's attributable to the diagnosis of cancer itself. And then if you've ever been diagnosed with cancer and you need help with daily tasks, that's where there's, once again, that 5-fold increase, 5 to 6-fold increase. So what you can see here is, regardless of whether you've got cancer or not, you have this 6-fold increased risk of psychological distress with needing help with daily tasks. And then down here we've got looking at that spread of functional limitations, which I showed you in the graph, really divides the population more sort of evenly. And what you can see then is, compared to people who've never been diagnosed with cancer who have no functional limitation, there's this gradient in the risk of high psychological distress, and in people who have severe functional limitation there's around an 8-fold increase in the risk of high psychological distress. But you can see that that pattern in people who've never been diagnosed with cancer is very similar to the pattern in people who've ever been diagnosed with cancer. So I think the bottom line here is that, yes, we do see increased risk of psychological distress here with the diagnosis and treatment of cancer. But the much larger risks that we see here are related to disability. And what we know from what we've looked at before is that cancer is related to that, is related to disability. So we're not saying that cancer doesn't lead to disability, which then leads to high psychological distress, but what we are saying is that in the absence of disability, there's not a huge long-term effect of a diagnosis of cancer on the risk of high psychological distress. So I might just pause there. But actually, if anyone's got any questions about this picture, maybe they could ask it now while it's up there. No? Okay, maybe leave it to the end. Okay, so then just looking in more detail at the cancer types, and as I've said, because of the point of recruitment in the study and the point of data entry, because if you can imagine 266,000 questionnaires is about 2.6 tonnes of questionnaires that had to be entered. So in terms of actually then having to do the coding for various subtypes of cancer, we've only just finished doing that. So we were not able to include those data here. So what we're looking at here is the odds ratio for psychological distress in men and in women, looking at the specific cancer types that we were able to separate out. And this is just that ever-never dichotomy. So the ever includes recent treatment, not recent treatment, disability, not disabled. So what you can see first of all is that people who have a diagnosis of prostate cancer, and this is mostly people who are long-term survivors, there's no significant increase in the risk of psychological distress. There's a suggestion of an increased risk of psychological distress in people diagnosed with melanoma and not with non-melanoma skin cancer. But where there is an increased risk is in people diagnosed with other cancers in both the men and women. We also see that actually a diagnosis of breast cancer is not, in the long term, is not associated with a significant increase in risk, nor is the diagnosis of melanoma. And there's actually a suggestion that people with non-melanoma skin cancer are actually slightly happier than everybody else. I don't really know how to interpret that. It's probably within the play of chance there. So if we then look at people who've been treated for cancer in the last month, and once again we're still comparing them to people who've never had cancer, then what you see is increased risks of psychological distress, particularly with melanoma, but also particularly here with the other cancers, which is likely to include quite a lot of quite serious cancers. And we see that in women as well. It's interesting to see that melanoma is associated with, well, looks like it's associated with increased risk of psychological distress when it's not necessarily very serious in terms of actually having to have things removed. But anyway, it's interesting to see that. And then if we look among people, so dividing it into treated and not treated, we then see that among people who are not treated, who haven't been treated in the last month, then really there's no obvious significantly increased risk. This one is significantly raised, but it's quite consistent with the other one. So there are no large increases in risk among people not treated. So if we then go into the daily tasks thing again, looking at people who have the different cancer types but don't need help with daily tasks, once again we do see this increase in risk in people who have the other cancers, possibly with melanoma, but not very large increases in risk all round. And these are the odds ratios for when people need help with daily tasks. So you can see once again we're in the sort of 5-fold, 6-fold, 7-fold, regardless of the type of cancer that people have. So in conclusion, I mean, in a way this probably now is quite intuitive, and what I find with epidemiology is a lot of people go, oh, you're just proving the self-evident. But what I think happens sometimes with epidemiology is people have a whole range of beliefs, and which they don't know which ones are based on evidence and which are not. I mean, and some of them are based on evidence which is to do with their own experiences. And then an epidemiological finding comes up and they go, well, I know that that's part of one of the things I already believe. But I do think that there's a difference between things that you know in a more general sense and things where you have solid data of this nature to back them up. So what we see is increased psychological distress in people diagnosed within the previous year, people have been treated in the previous month, and people needing help with daily tasks. There's a minimal increase in risk of high psychological distress in the absence of disability. So we're talking about 11%, 14% increase in risk. And so the excess risk associated with disability is around 40 times greater than that with just cancer alone. Now, I also want to point out that other risks should be considered. So I haven't included in here, for example, whether or not someone's had a previous episode of depression in the past. And what we find with that is they have a 6-fold increase in the risk. So if you have previous episode of depression in the past, and you also have a disability, then you end up with around a 30-fold increase in the risk of psychological distress. So these risk factors multiply together. But that's not the focus of this particular talk. But what I'd like to point out is that you do need to take into account other risk factors for depression. So it's also true that a substantial proportion of people with a significant disability are experiencing high psychological distress, whether or not they have cancer. But it also says that people are generally able to adapt to a diagnosis of cancer, especially if they remain able-bodied. And I also would like to finish here by saying that high psychological distress is very common. So we're talking about 7.5% of the population anyway, so I think it's very helpful to watch out for the signs of depression and anxiety in your loved ones. So I'd once again like to acknowledge my collaborators and the people who supported the study and the participants. And I just finish with the paper itself if people want to actually learn more. That the paper's outside, but it's also available on the web. Thank you very much.
Thank you very much, Emily. And I think we've got time for some questions. So, is there anyone? Yes? Thank you. If you could speak loudly because we don't have time.
Two components. One is the non-melanoma skin cancers. Does that include relatively trivial things such as keratosis and basal cell carcinoma, which are very treatable? Does it?
Yeah, so what it was people answering that question, has a doctor ever told you you have any of the following? And it says skin cancer in brackets, not melanoma. So it's actually what people themselves think is a skin cancer. So it is likely to include solar keratosis. We actually are in the process of comparing what people have said on that with pathology reports. So we're not exactly sure what proportion are truly skin cancers, but yes, it would include quite very treatable things.
The second was general population screening for things like prostate cancer or breast cancer. Mm-hmm. It's been said that it will cause so much distress to people to hear that they have something like prostate cancer that may have been asymptomatic and may not do them any harm, that it's better that they just don't ask the question and don't know. But these results would suggest that people don't get that upset if they're told they've got a cancer and their prognosis doesn't look bad.
Okay. I think there's about 20 questions in that question. Well, the first is, it's absolutely true that we need to really very carefully evaluate the effect of a screening program on the overall risks and benefits of a screening program. So breast cancer screening has been kind of through that mill, and we're now seeing quite a lot of results regarding survival and reductions in mortality that are probably related to both better treatment of breast cancer, but also to breast cancer screening. Prostate-specific antigen screening for prostate cancer is a lot more controversial because the actual effects for a man of having had their prostate removed can be quite substantial. Not that having had a lump out of your breast or having a mastectomy is trivial, but more in terms of urinary function and in terms of erectile dysfunction. So there are also a lot of outstanding questions about when screening should start and that sort of thing. So I think there are general controversies there. This does suggest that people can adapt to the diagnosis, but that in some ways doesn't say that the effects are trivial or should be ignored, because what we've also shown is that people often look back and say, well, I may have problems with incontinence now, but I'm glad that prostate cancer's out. So people do actually justify things in retrospect. So if you ask people before a prostate operation, how would they feel if they were impotent? They answer that quite differently after the operation. So we do, I think, as part of a duty of care, have to think about that this is supportive that people are adapting and they're okay, but it doesn't obviate the need for a duty of care about forcing people to adapt to something that may not actually be necessary to adapt to.
Thanks.
No worries.
Was your choice of 45-year-olds over arbitrary or some cut-off point of a particular sort?
Of a particular cut-off point. It was mainly related to when a lot of the common causes of morbidity and mortality start to take off. So the 45 and up study is designed as a study of healthy ageing. So that was a sort of general cut-off point. It was also seen as just prior to menopause for women, just prior to some of the other commencement of some of the cardiovascular problems that men have. So yeah, I mean, it is in some senses arbitrary, but it was meant to be sort of old adult cohort.
Yeah.
What
repeat the question. The question is, do we have data to look at different types of treatment and different stages of cancer? And the answer is we didn't have it for this data set, but it would be a very interesting thing to look at down the track. So we will have, it is possible to get some of that information. And I think but not at this point. And so we're not necessarily going to look at that, but I think it would be very interesting. Julia.
Hi, yes, a wonderful presentation, Emily. I had a question about people who are, you mentioned about best diagnosed with depression. If people are currently depressed, clinically depressed, do their levels of distress go much higher once they are diagnosed with cancer? Is that possible?
Yeah, we were not able to actually distinguish that because this was just one snapshot, one point in time. They could say, yes, I'm being treated for depression or anxiety, and we couldn't really tell whether that was, and then they would have a high K10 score, and we couldn't really tell what came first. So we could only really look at people who reported that they'd ever been diagnosed with it in the past. And this was a sort of subsidiary analysis, which I'm not presenting here, but what we did was just as an exploration. We looked at people who'd been diagnosed with it in the past, and we could actually see from from the age they were diagnosed that it was well before they had the cancer. And we then looked at if they currently had a diagnosis. So, but we were not able to really tease those things out. And I think that that's the kind of thing that was very useful to look at in this study because we're following people up in the long term. So we're just formulating the 5-yearly follow-up questionnaire. We're going to do another one at 10 years. So we'll be able to look at who had depression in the baseline questionnaire, who was diagnosed with cancer in the interim, and then we can look at piecing that story together, which I think is really interesting.
In some of your later tables, I think I saw that odds ratios were less than 1, like 0.82 for women with breast cancer, for example. And the range, the error bars went up to 1, but only just up to 1. Do you think that that's statistical noise, or can you think of any reason why having breast cancer would be protective against distress?
Yeah, well, I think I tend to do this thing which is I call putting on a pair of statistical glasses. When I put them on, I can only see things that are statistically significant. I can't see anything else. So even though those point estimates suggest it might be protective, it still wasn't significant. If you wanted to speculate, women who have breast cancer tend to be higher socioeconomic status, fewer children at a later age, exposure to exogenous hormones, they tend to be fatter. There's a whole lot of factors that fit in with a risk of breast cancer that might influence a person's risk of psychological distress. So it is possible that there are actually factors relating to the risk of breast cancer that actually are related to a lower risk of psychological distress. Alternatively, it may be that I'm just speculating now completely, but it may be that people who have a diagnosis of cancer, there's factors related to that experience and to the support around them that actually enrich their lives. I think it's probably a question you need to ask people who've been through breast cancer, and it needs a lot more exploration, but it's an interesting point nonetheless. But as a scientist, I have to say that my first thing is it's not significant, so that would be the bottom line.
Yes, I think breast cancer is in the media has become a little bit less scary. So it seems to be picked up a lot earlier. It's treated better, and I think that people are less prone to getting upset about it now. I think it's probably they say that people recover more from breast cancer now than they do even with lung cancer.
Well, certainly, I think that's one point that has been picked up in the previous literature too, that there are some very poor prognosis cancers like lung cancer, which are associated with quite a lot of distress, and that actually the process of one of the things that the breast cancer screening program, but also all the sort of pink campaigns have really done is to make things much easier for people. Not that it's ever easier, but it's better now for people with breast cancer than it was before. So it's being picked up at an earlier point. The treatment's better coordinated. There's a lot more support. And I've also heard people now saying that that actually almost there's a sort of discrimination within cancer, that for other cancer types there isn't quite the same publicity and there isn't quite the same support, and that we need to extend some of what we've learnt about breast cancer to the other cancers. So I think it's a bit of a watch. That's a bit of a watch this space. Yes.
I was just intrigued in looking at your list of disability that some of the things like no longer having one or two breasts and perhaps erectile dysfunction wouldn't necessarily be covered in that list of disability, and I just wondered if there's any information about how they affect.
Yeah. Well, I think, as I said at the beginning, it's a blunt instrument.
Yeah.
And we certainly do, actually, we do have questions in that questionnaire about erectile dysfunction in men. We don't have anything about sexual dysfunction in women. And I think it's the largest study in the world that has information on erectile dysfunction, and there's certainly a project underway looking at relationships between prostate cancer diagnosis and erectile dysfunction. We do have some measures of overall quality of life, but we don't have anything about whether or not you've had a breast removed or body image or satisfaction with those things. So it's one of the things the 45 and up study is a large-scale collaborative study. We had 120 collaborating researchers, and there are 58 questions on the questionnaire. So you can imagine the bun fight to get those questions sorted out. But it's certainly a good point, and I think it is one of the limitations of this study.
Sorry, you talk about stress increasing in disability. Did you look at any patients that might have had brain cancers and had operations and therefore ended up with a cognitive dysfunction, which is not actually a physical thing, but it still impacts on how they live their lives?
Well, we didn't have the other cancer category coded, which means they might have written brain cancer there, but we hadn't then yet put it into the International Classification of Diseases version 10 yet. So that's something that we would probably look at subsequently, and I think particularly looking at it in relation to cancer registrations, because although it's broad, people are pretty good broadly at saying that they've had cancer or not, there are things in there that aren't necessarily accurate, because you're often trying to categorise things based on lay language about what it means. So no, we were not able to look at that.
Any other questions? Yeah, down the front.
This is a qualitative aspect to that. I just wonder, speaking anecdotally, how you travel through cancer, often is significantly determined by your relationship with treating doctors. And the stats indicated to me, perhaps, that kudos should pay to the breast cancer specialists, because obviously, women with breast cancer, are travelling better than with some of the other cancers. And I just wonder whether in your analysis there's anything to sort of address, that relationship with the treating doctors, and whether you have a lot of confidence and feel very supported by them, or whether they wrap you up the wrong way. Annoy you and have time to sort of listen patiently.
Yeah. Well, there's at least one study underway in 45 and up that's using a sort of framework of the 45 and up study to get more details about colorectal cancer and the patterns of care in colorectal cancer. So that also includes whether you had a multidisciplinary team or where you were cared for. To my knowledge, there are no studies underway currently that actually ask about the sort of narrative or the patient experience, but I think that would be a very useful area to look at, particularly the rub you up the wrong way question. You can have a score there. No, I mean, sorry, I don't mean to trivialise. I'm more meaning that I think that would be a really important area to look at, and it is definitely a more qualitative area, but it's not covered by the current data.
The other question that I always find intriguing about cancer is that the language we use around that you battle bravely against this vicious disease. So there's all this stuff about attitude and the attitude with which you do things. And in fact, I think there's an enormous burden on cancer sufferers to be chipper and positive, because otherwise they're bringing their own doom upon themselves, kind of. And I presume that's really not something that a study like this can deal with?
Yeah, well, there's been quite a long literature about whether stress increases the risk of cancer. Mm-hmm. And I think that's pretty much been put to bed, that stress is not a cause of cancer. The question about the language around cancer and whether an attitude helps prognosis, I really don't. I mean, we don't have those data. It would be very interesting to look at it. There's certainly a little bit of difficulty there, because also when people actually have a setback, like you know, there's some evidence that the cancer's spread or it's a worse prognosis, then that does actually make people feel down. So there's actually a link between how you feel and your prognosis anyway. But I think that probably the issue about what people who are diagnosed with cancer need and what's most appropriate really is, it's about being understanding and negotiating and letting people have the space to be exactly how they are. And that's really quite a large part, education and compassion and all those other, and empathy and all those other things. So I'm not sure that this study really does have much to offer there, except to say, I mean, I think it's quite a message of hope that actually really once we've quantitatively gotten rid of the disability-related things and the recent treatment, it really does look like there's quite a positive message in the long term.
Given the time, perhaps on that more positive note, we'll draw this evening to a conclusion. But please join me again in thanking Emily for her insightful response to the studies and her very candid responses to your questions. And thank you for your questions.